Hi, good morning, everyone. I'm Xin-Hui, one of the doctors from Tan Tock Seng Hospital in Singapore. Thank you for the privilege of presenting at cases today. So this study is about advanced adenoma and colorectal adenocarcinoma in a tertiary referral center in Singapore, focusing on the screening outcomes and the risk factors. I have no disclosures. Colorectal cancer is the second most common cancer in Singapore for both the males and females. The lifetime risk of colorectal cancer is 4% in males and 3% in females. Despite a nationwide screening guidelines, there's still increased onset of early onset colorectal cancer in Singapore and also overseas. This refers to patients diagnosed with colorectal cancer at the age of less than 50 years old. The aim of this study is to assess the risk factors for advanced adenoma and adenocarcinoma, further stratify patients, and to come up with more targeted investigations and hence improve patient care. So this is the guidelines or screening guidelines for colorectal cancer in Singapore. Patients are stratified into high-risk patients versus average-risk patients. Patients who are high risk refers to those with family history of colorectal cancer or related cancers, familial syndromes such as FAP or IBD. They are encouraged to go for colonoscopy. For patients who are average risk, screening starts at 50 years old and above. They are recommended to go for FIT or fecal immunochemical tests annually, colonoscopy every 10 years, or CT colonography every 5 years. The diagram on the right shows the sensitivity as well as the frequency of screening. Fecal occult blood test is increasingly phased out because of the lower sensitivity. So this is more about the hospital where this study was taken place in. Tan Tock Seng Hospital is one of the largest tertiary hospitals in Singapore. One of the unique things about the hospital is that it's located within the older housing estates. Hence, most of the patients are quite elderly. So for the inpatients, more than 50% of the patients are aged 65 years old and above, as compared to the nationwide average of 29%. So our study was taking place between December 2023 to May 2025. Over this 1.5 year period, the patients included were first visits to the colorectal clinic, including patients who presented with symptomatic conditions, asymptomatic screening, or were referred because of FIT positive. 2,777 patients underwent colonoscopy, of which 42% had polyps and 2% had tumors. For those with polyps, 16% had advanced adenoma and 1.6% had adenocarcinoma. The definition of advanced adenoma, or AA for short, refers to villus component of more than 25%, size of 1 cm or more, or high-grade dysplasia. For the patients with tumors, 16% had advanced adenoma and 69% had adenocarcinoma. These are the results from our study. It shows the association between each risk factor and the development of AA or adenocarcinoma. The results that are yellow are those that are statistically significant, and we will be elaborating more about them later. Firstly, FIT was able to detect both AA and adenocarcinoma. For patients that are FIT positive, the risk of advanced adenoma was 2.85 times higher risk, and for adenocarcinoma, it was twice-fold higher. For those with tenesmus and change in stool caliber, the risk of adenocarcinoma was 3.56 times. When analyzing patients with AA, it was noted that most of them were asymptomatic. In fact, patients who were asymptomatic had 15 times higher risk of AA as compared to patients who were symptomatic. Expectedly, patients with more symptoms had higher risk of adenocarcinoma. In our study, CT colonography was less effective than colonoscopy in detecting AA. Patients with abnormal imaging had a 9-fold increased risk of adenocarcinoma, however, not for AA. These findings reinforce that colonoscopy remains the gold standard for detection. As a follow-up to this study, we are currently conducting a comparative trial evaluating the alternative to FIT. ColoSafe is a stool DNA test that detects tumor-derived DNA in the stools, in contrast to FIT, which detects human hemoglobin. A study in China reported specificity of 98%, compared with 90 to 95% for FIT. Hence, we are trying to validate this in our local study. These findings suggest that stool DNA testing is a potential alternative to FIT with higher specificity. In conclusion, this study was conducted at our tertiary institution and it demonstrated that positive FIT, tenesmus, as well as change in bowel habits are key risk factors with the development of AA and adenocarcinoma. There was a large number of patients who had normal scopes, highlighting the difficulty in accurately identifying high-risk individuals. With the advance of personalized medicine, this can allow for individualization of the starting age, screening intervals, and choice of screening modality, hence reducing the number of unnecessary scopes. While colonoscopy remains the gold standard for colorectal screening, FIT remains a non-invasive alternative for average risk patients. Thank you.
Good morning, everyone. Thank you, Chairman, for giving me the opportunity to present a topic on a single-center experience with adoption of ICA, intracorporeal anastomosis, in Teng Hospital, Singapore. I have no any disclosure on this. So, first of all, what is extracorporeal and what is intracorporeal anastomosis? In EA, bowel transection and anastomosis is performed after exteriorization of the bowel through a mini laparotomy, whereas in IA, intracorporeal anastomosis is conducted entirely laparoscopically, with the specimen retrieval through a small extraction site, for example, a phalansteal incision. So what are the clinical promise of intracorporeal anastomosis? Why move on to it? Literature suggests that it reduces mesenteric twisting due to less mobilization, smaller incision, and faster recovery. Also, it shows that there's a lower surgical stress response as well. But it comes with a learning curve challenge and why the adoption has been limited, because there's technical difficulty associated with intracorporeal anastomosis, suturing, orientation, and enterotomy closure. So what are the outcomes and recovery based on multiple meta-analysis and also studies from ICA? So ICA is associated with these several short-term outcomes, for example, faster GI recovery, less post-surgical pain, which both leads to a shorter length of stay and also leads to less complication rates as well, which study shows that it decreased wound-related complications such as excision hernia, also suggests fewer anastomotic-related complications. So these are the example of a study done by Tata et al. In 2013, shows that there's significantly, statistically significant less complications in terms of SSI, anastomotic leak, and also ileus as compared to the EA study. Also, it shows statistically significant less length of stay in the IA group compared to the EA group. Also, as mentioned, it reduced the surgical stress response as well. A primary physiological advantage of IA is the attenuation of systemic inflammatory response. Why so? It's because it might be attributed to the reduced tissue manipulation and mobilization, which are unavoidable in the ECA approach. So as depicted in the table above, can see that from post-update 1, 3, and 5, the CRP and the white cell count, IL-6, is significantly lower in the group, in the ICA group in this study. So in our study, our objective is to evaluate the early outcomes of transitioning from ECA to ICA in a single center in Fong Hospital, Singapore. So we did a retrospective comparative study of 15 elective cases on both arms for both ECA and ICA group from July 2025 to February 2026. In ECA group, we do standard laparoscopic assisted approach, and in the ICA group, we do a total laparoscopic approach. So for our patient demographics, our ECA group median is 75-year-old, whereas ICA is 67-year-old. BMI, the mean is 22.6 in the ECA group, and ICA, the mean is 25.1. This aligns with some literature that says that ICA is often preferred or more beneficial with patients with higher BMI because it avoids the need of exteriorize the mesentery. For the patient's diagnosis, we do primary cecal cancer, ascending colon adenoCA, descending colon adenoCA, sigmoid adenoCA, and all cases were performed electively with standard oncological resection. So this is our mean operative time in our study. In this study, the mean operative time is 57 minutes more in the ICA group compared to the ECA group. So to stress on this, there's a box and whisker plot that we plotted for our patients in terms of our outcome. So can see the length of stay for the median of the patient with discharge is 2 days earlier in the ICA arm, 4 versus 6 days in median, with a p-value of 0.031, confidence level of 95%. So there is a statistically significant reduction in stay, whereas for you can see the outlier, which in the ICA group is 11 days. This is due to inadvertent complications intraoperatively that I will going to explain later. However, you can see that in the ICA group, it is much more tighter in the distribution, meaning that the discharge timing was much more predictable and is statistically significant. In terms of the bowel function, while the passage of flatus showed a trend, 0.097, the time to first bowel motion reached statistically significant. This suggests that ICA technique provide more definitive advantage in terms of return of full intestinal peristalsis, likely due to the reduced mesenteric handling. So looking at the outliers, the individual dots can see shows that the ECA group had several patients with prolonged recovery, whereas in the ICA group, can see that there's fewer and there's one outlier, which, as mentioned, I'm going to explain later. In terms of inflammatory outcome markers, however, there's a paradox in our study. While the literature suggests that ICA reduced surgical stress response, our center shows early experience shows higher CRP level. So this correlates with our longer operative time and highlight the physiological cause of this learning curve. So we think that as we gain efficiency in our technique in ICA, we expect that this level to align closely with the established literature. This goes same with the total white cell trend as well. So in comparison, ECA versus ICA, we can see that in ECA left hemicolectomy shows substantially higher inflammatory response, possibly due to the involvement of splenic fracture mobilization. Whereas in ICA, we can see that it was relatively stable across both arms, likely due to ICA standardized the surgical stress response. So in both ECA and ICA arm, from July 2025 to February 26, there's no any anastomotic leak that was observed. 3 patients in the ECA group was complicated with anastomotic bleeding requiring sigmoidoscopy and clipping, and 1 with adhesions mobile obstruction which admitted to hospital postoperatively. Whereas in the ICA group, as 1 patient had an intraoperative event of hemorrhagic shock secondary to inadvertent dissection into the capsule of head of pancreas. And this leads to a prolonged hospital stay for this patient. Whereas there are other 2 which had post-operative ileus. In terms of oncological and pathological outcomes, all patients had 100% R0 resection for both groups. All specimens showed clear margins in regards to which technique. Whereas for lymph node U, it shows that both techniques meet standard requirement of more than 12 nodes for adequate staging. Whereas in ICA group, it shows a higher lymph node or mean U of 21 nodes compared to ECA U of 17 nodes. So what are the lessons learned from our study here? We all can observe a physiological recovery for the patient despite the higher CRP and longer operative time. ICA patients recovered bowel function faster and were discharged sooner. But however, there's a hump to it, where there's a 57 minutes operative difference, and this is expected to be narrowed down as we complete the learning curve. The trade-off is we are trading longer operative time for faster bowel recovery, shorter hospital stay, better patient outcome. What the take-home message for this? ICA is a safe technique. from this 7 months study with 2 consultants performing ICA, it shows that there's no increased rate of leak, no recurrence in our study, without compromising oncological safety and quality. So it shows significant reduction in hospital stay, faster return to GI function. So what is our main focus in the future? We'll be mounting the learning curve to a next level of minimally invasive care to our patients with standardized ICA to reduce operative time and further attenuate the stress response. Hopefully that we can provide better outcomes for our patient. These are my reference. Thank you very much.
Good morning, everyone. It is a great honor to present these findings on the learning curve of a specific laparoscopic technique for pediatric hernia repair. I have no financial interest or disclosures to declare. Pediatric inguinal hernia is one of the most frequently encountered surgical conditions for pediatric surgeons, especially in extremely low birth weight infants, where the incidence can be as high as 30%. While traditional open high ligation has been the gold standard for decades, the surgical landscape is shifting. Laparoscopic surgery is increasingly preferred because it offers superior visualization of the internal ring and allows for the easy identification and repair of a contralateral patent processus vaginalis. Today, I will focus on the list PS technique, laparoscopic intracorporeal sac transaction, and pulse string suture. This method is particularly significant because it strictly adheres to the surgical principles of open high ligation, though it is often perceived to have a steeper technical learning curve than other laparoscopic methods. The purpose of study was to quantify this steep learning curve. I aimed to identify the exact point of technical proficiency using QSUM analysis, comparing the clinical outcomes between the learning and proficiency phases, and specifically evaluate whether this technique is efficient and safe for high-risk patient groups. I conducted a retrospective review of all patients under the age of 18 who underwent list PS at our institution between March 2019 and December 2025. To maintain the integrity of the learning curve data, I excluded cases that involved combined operations or those performed by other surgeons. Investigated factors were patients' demographics, hernia laterality, operative time, recurrence, and follow-up period. Definitions in this study. Learning phase means before proficiency point. Proficiency phase means after proficiency point. And high-risk group means preterm birth and under 1 age-year-old at surgery. The list PS procedure was performed in a standardized manner. Under general anesthesia, 3-port approach was utilized. The hernia sac was completely transected circumferentially, followed by an intracorporeal figure of 8 pulse string suture, as demonstrated in this image. I used 5 or 4 micril materials. After exclusion, I said in the method, total 469 patients were enrolled. The mean age and body weight at the time of surgery were 3.4 years and 15 kilograms respectively. Approximately 65% of the patients were male. Regarding clinical status, 17 cases were performed, hospitalized in the NICU, and 12 cases were emergency surgeries. Interestingly, while only 9% of cases were preoperatively diagnosed as bilateral, this figure increased to 48% postoperatively after laparoscopic exploration. The overall mean operative time was 16 minutes, and the recurrence rate was 1.7%. This graph illustrates the sequential operative time. There is a gradual and steady decline in operative time, reflecting the progression of the learning process. And this slide illustrates the recurrence pattern. The overall recurrence rate was 1.7%, and as shown in the graph, these cases were randomly distributed. In the QSUM plot, the operative time reached its peak at the 203 third case. Based on this inflection point, we divided the study into two groups, the learning phase and the proficiency phase. Regarding patient demographics, there were no statistically significant differences between the two phases. The mean age was around 3.3 years, and the mean weight was approximately 15 kilograms. About 30% of our patients in both groups were born prematurely, and we handled a similar distribution of right or left and bilateral cases. This balance ensures that our comparison of operative efficiency is not biased by patient complexity. The most striking difference was found in operative efficiency. The mean operative time dropped significantly from 70 minutes in the learning phase to 52 minutes in the proficiency phase. This is a nearly 20-minute reduction, which is typically highly significant with a p-value of less than 0.01 point. But what about safety? A common concern during the learning curve is the risk of complications or recurrence. However, our data shows that the recurrence rate was exactly 1.7% in both phases. This indicates that while the speed of the procedure takes time to master, the efficiency of the repair is established early on. I also performed a subgroup analysis on high-risk patients, specifically infants under 1 year of age and those with a history of prematurity. Working in the small abdominal cavity of a neonate or infant is technically demanding. Even in these challenging cases, we observed a significant decrease in operative time. As presented in this table, although the high-risk group required a longer operative time, the recurrence rate remains comparable to that of the control group, showing no statistically significant difference. In summary, our study identifies that the learning curve for list PS in pediatric inguinal hernia repair is approximately 233 cases. The meticulous dissection and intracorporeal pulse string suture within a confined working space likely contributed to this extended learning curve. Mean operative time decreased from 17 minutes in the learning phase to 50 minutes in the proficiency phase, while the recurrence rate remained stable at 1.7% across both periods. Technical improvement follows a parallel trajectory across all patient groups, confirming that list PS is a reliable and definitive approach for both standard and high-risk pediatric patients. Yeah, thank you for your attention.